Well, hey everybody, it looks like we're all here, so we'll go ahead and get started. Thank you and welcome to the ENT-Cloud MIPS MACRA webinar. Real quick, by way of introductions, just so you know who you're talking to. My name is Dave Beatty. I run the sales teams over here at ENT-Cloud, and joined with me here is Risa Barbalich. She is our resident expert at all things MIPS and MACRA. She spends most of her days stalking CMS online to see what it is that they changed recently, and you'll hear from her here in our Q&A section here in just a little bit. Just so you understand who is giving this presentation, we are ENT-Cloud. We are a software vendor for software and services for medical records, specifically in the ENT, audiology, allergy specialty. We were founded in the year 2000 by Dr. Larry Gordon up in Goshen, New York, and then joined also with Larry, as you might know, is Dr. KJ Lee. You may have read his book on how to pass your boards in otolaryngology. He is on our board over here, and he is a great resource for us as well, just so you know that is somebody who is on our team over here. Back over to our ENT-Cloud slide here. We have a couple of awards that we're pretty proud of. Things like we were the first company to really develop the patient portal and have patients be able to go online and check to see or be able to check in online and see what their insurance is and their medical history, their health history, and so forth, and do all that before the patient walks in the door. Tempur gave us that award back in 2007. We were also the first true cloud-based ONC certified EMR, and when I say true cloud-based, what I'm referring to is something that's actually using a browser. There's not an app to download, no Citrix firewalls or anything like that. You just simply go into a browser, put your name and password, and you are off and running. We also have a really nice award from SureScripts. It's called the White Coat of Quality Award, and effectively what that does is we've integrated all of SureScripts information into a single screen, both with today's medications or past medications, both things that you've prescribed and you haven't prescribed, things from other physicians and so forth, all the things on one single screen. We do have users in all 50 states and in Puerto Rico as well. So what are the MIPS requirements? I assume if you're on the phone with us today, your goal really is to learn more about MIPS and MACRA. Just by way of disclaimers, our goal today is more informational than educational. We're going to try and do this in a large overview as opposed to being specifically educational. And another reason for that is that CMS is still taking, well, they just finished taking their comments on the requirements at the end of December. So we expect one more final rule, however many finals that was, from CMS coming up here in the next week or so. Risa could probably touch on that a little bit when she comes up. But as of right now, the rule stands at over 800 pages of legislation and rules and guidelines and so forth that we have to follow. So this is a constantly changing landscape so far as it relates to MIPS. And that's part of the reason why we wanted to have this kind of say where we're at today. Let's talk about how this all breaks down here. First of all, who is required to participate? It's pretty important. People who are required to participate are physicians, PAs, NPs, the clinical nurse specialists, as well as a certified registered nurse anesthetists as well. This is about Medicare. Medicare Part B clinicians, you have to be doing more than $30,000 a year and providing care for more than 100 patients. So if that is you, then this definitely is, you are required to participate. Now, who is exempt? Who does not have to participate? So that would be anybody who falls below the $30,000 mark on an annual basis in Medicare, not Medicaid, just Medicare, or less than 100 patients on an annual basis. Providers who are brand new to Medicare. I'm not talking about providers who hadn't participated in any of their programs before, like PQRS and meaningful use in those things. I'm talking about a brand new provider who saw their first Medicare patient in their entire lifetime in 2017. If that is the case, then they would be considered exempt for 2017, but it picks right up in 2018. Lastly, providers who are participating in advanced alternative payment methods or models, excuse me, or called APMs. That is beyond the scope of our conversation today. Okay. When does MIPS take effect? Here's kind of the way that this is going to roll out. 2017 is really the first year where we're evaluating performance, and that performance is going to be evaluated for payments coming in 2019. So follow me through here. 2017, we're going to start collecting the data. Whether that's you started on January 1st, a little late for that, or you're doing just a quarter by the end of the year, you'll be able to submit that data. Data has to be submitted by March 31st of 2018. There'll be a short feedback period, and then based upon your data, and by January of 2019, the adjustments will take place for the better or for the worse or for net zero sum. They'll start taking effect 2019. So again, data that you're submitting in 2017 is going to impact payments that you're going to receive starting in 2019, and that's how that's going to work. That timeline, just as I said, starting off at 2017, 2019, you'll start to see a adjustment on the payment, and it's going to start in 2019 with a 4% swing either direction, which means that you can either get 4% bonus or a 4% penalty. And then it goes up each year, so that it goes 5% 2020, 7%, 9% of 2022. And again, that's a swing either direction. You could possibly get up to a 9% bonus or a 9% penalty. How does that work? How do all these things kind of go together? The score is a composite. In years past, with the meaningful use, PQRS, CQMs, all those programs that we as an industry got together and said, it is time for us to have a single program. So to put it in short words, we asked for this. This is something that we wanted to do. We want to have everything under a single program. So in the prior programs, there was some just straight numbers. It's now based on a percentage basis. So it's based on more like you would get when you're in college. You are getting scored and a percentage. How did you score? A, B, C, D, F. And then according to that scoring, you will be able to possibly get more incentives, and at the very least avoid the penalty, which is something that I think everybody here has the ability to do. Let me stress that, and I think that that's something you should know at the light in the tunnel here. This is something that is very, very possible, and it's very, very achievable. So it's a composite of the base score, the performance score, and the bonus with a composite score. Here's how all that breaks down. In 2017, your score is going to be made up of 60% of the quality performance initiatives. It's going to be made up 25% of the advancing care initiatives and 15% of the practice improvement activities. So let's just go through those just at a glance so you understand what we're talking about. The quality improvement, I want to talk about these real quick. So the quality improvement is effectively what PQRS was. So if you're familiar with PQRS, that is what the quality performance equals. And there are 271 different measures that we can check on for PQRS. If we look at the advancing care, which this one right here, the advancing care is effectively the same as meaningful use. The meaningful use side of things, it's 5 to 9 measures and 15 to select from, represents about 25% of the total score for MIPS in that year. The new category is the clinical practice improvement activities. That's a brand new category for MIPS and MACRA, and we're going to talk about that here as we get into it. And you have to do 4 of 93 different activities equaling a total of 60 points. Okay, and I'll show you that here at the end too, so don't forget to write all that down. As we go through 2018, we start to reduce some of the quality performance initiatives in place of some cost performance pieces in 2018. 2019, that increases to 30%. So we'll start to see these change as we go through time. Okay. Now here's a good question. Why should you participate? Zero participation, pretty straightforward, you're going to get dinged. So a 4% cut, 4% penalty in your reimbursements based upon how you do this year in 2017. You can participate minimally, even just doing one measure or activity, and you could avoid a downward payment in 2019. This goes back to what I was mentioning earlier, which is that it is very, very possible with a certified EHR system to be able to, at least at the minimum, avoid a penalty. And we'll chat about that. The next thing would be if you do a partial submission, like for instance 90 days of data in 2017, it could either be neutral, avoiding the penalty, or a small adjustment depending upon how you score. This is an interesting statistic because it is a 90 days of your choosing. It is actually better to do really well for a 90-day period than it is to do sort of okay for the entire year. So if you're just getting started with MIPS and MACRA, you're thinking, oh, well, it's January, we got to get started right now, right this second, realizing it's going to take some time to get up and running on it. If you were to score, let's just say for argument's sake, a C for the entire year, but by the end of the year, that the last quarter, you guys were rocking and you had an A, it's better to submit the 90 days of an A than it is to submit the entire year. Just a side point there for you. The last one would be the full participation for the full year, and that would be that the moderate positive payment increase. I think the best way to demonstrate what this looks like is to actually show a day in the life. So what does it look like on a daily basis for a physician? How does this impact your life? So the best way to do that is to show my example here of my imaginary doctor, Dr. Claudia Cloud. And for the sake of this discussion, she is the mom of 2 young children. She is a solo ENT surgeon. She is independent and she likes staying that way. She is using our software, our ENT-Cloud software. She does about 40 patients a day and does surgeries on Tuesdays at the hospital. So there is your picture of my example physician here. So let's start off the first thing of the day. So Dr. Cloud's going to show up. She's going to have her Starbucks in hand. She's going to sit down at her desk, and she's going to be able to open up her computer, and she's going to see a to-do list. Some people call it a dashboard, to-dos, tasks, inbox, email. You could call it a thousand different things, but those things can be several things that are going to come up, and those might be something as simple as a lab result that needs to be reviewed or an imaging that's come back in from the radiologist. Also things like, for instance, let's say yesterday Dr. Cloud prescribed a medication to a patient, and when the patient got home, their spouse said, oh, don't forget, honey, when you take that, your stomach gets upset. And the patient logged into the portal and asked for a different medication. That could all be all on that same screen, and that's all starting to take away some of these phone calls and return phone calls that we've had to do in the past, all the while adding good to the score for MIPS and MACRA. So let's see our first patient. So Dr. Cloud is going to see Sean's sniffles. He's a 12-year-old patient complaining of facial pain and pressure. Doctor is going to sit down with the patient. The MA in the practice would have already done the patient's vital signs, already gotten the review of systems from the patient and mom and dad, whoever brought the patient, medication list. All those things should have been already done by the time the doctor came in. So she's going to review that, make sure all those will come in. Dr. Cloud is going to reconcile the med list, and in the same screen be also to prescribe Flonase and amoxicillin. Doctor is going to review the care plan with the patient, and in this case with the patient's parents, and she's going to email the medication instructions and a visit summary to the patient, or in this case the patient's parents. What that's going to do is going to have a couple different requirements that have now been satisfied just with that simple visit: advancing care category and the quality measure, which is the medication reconciliation. So just in that very simple visit, we've done 2 things as requirements. Let's see our next patient. Our next patient is Nancy Newton. She is 68. She has some allergy symptoms. She is transitioning care from another practice. She just moved into town from Springfield, and her other doctor, who's of course Dr. Simpson, sent a continuity of care record over to our practice for this patient. So again, patient's never been seen before in this practice. So the MA who rooms the patient is, because the other practice, Dr. Simpson, who is using, he could be using our software, he could also be using another ONC certified system. Because they're using the ability to do that, they can send a secure message over, and that secure message can land into our inbox, and the MA who's rooming the patient can import the patient's medication list from the other doctor, their allergy list, their problem list, and a copy of that patient's record, if you will, into the patient's chart, all in one step. So there's not having to put in all these things manually like we've had to do in the past if the patient's coming from another practice. So because of that, doctor is able to quickly sit down, reviews with the patient that they're going to recommend some allergy testing, and stop using Mucinex and start with both Zyrtec and Flonase. On the way out, that front desk staff is going to check out that patient and hand the patient a satisfaction survey. I'm going to talk about a special pen that we can use here in a few minutes. But if you're not, let me just encourage you guys, if you're not doing patient satisfaction surveys, they are incredibly useful. They're very insightful for a myriad of reasons. So if you haven't started doing those, I highly recommend it. We have a special pen that will actually help do it automatically, and we can chat about that here in a minute. This would be a couple of examples of both the advancing care and the improvement activities. Okay, so very straightforward visit. Next step, doctor is going to walk across the street and do her rounds. She rushed out the door. She accidentally left her main device, her laptop, sitting back in the practice. If she's using a product like ENT-Cloud, she can log into any device that she has, so whether it's a computer over at the hospital, whether it's a backup laptop, maybe her MacBook sitting in her trunk of her car, whatever the device is, she's able to log in on any device to see the patient. After doing her rounds, doctor's going to go back to her desk. She's going to see a sandwich wrap sitting on her desk for lunch. She is, remember, a solo physician. She's in private practice, and she likes being that way. She does rely on ENT-Cloud, who in this case is her technology partner, to keep her up to date on everything that's changing. Risa, as she will be happy to tell you at some point, she spends a large amount of time every single day getting up to date on the MIPS and MACRA because it's changing every single day. So Risa will do a late breaking news webinar, and she'll do those occasionally over a lunch hour and let everybody know that those are coming up. So in this case, my Dr. Cloud is, while she's eating her sandwich, is listening to the late breaking news from Risa. Let's go back to seeing patients. Our next patient is Samuel's swim team. He is a 19-year-old male, and he has some ear issues going on. This is a patient who needs to establish care. This is a college student in town, and as with most 19-year-old males, they don't like going to the doctor. They don't often go to the doctor, so they need to establish care. Okay. When Samuel first made that appointment to come and see the doctor, the front desk staff was good enough to send him an invitation to pre-register online. Back what I was referring to in the beginning, the fact that ENT-Cloud was the, if not the first provider to have a patient portal online. The patient would get an email, they'd click a link, and they would be able to put in their full history and all of their medications and anything else right on the screen before the patient even came in. So the patient is able to do that. So the patient gets their email, it fills out all their demographic information. They can even put a selfie up so they can, the patient can have their picture on their chart and so forth. All their social history, family history can be done. That email looks something like this right here. When the patient is seen, Dr. Cloud is able to review the patient's health history, prescription history, and see in this case that the patient's previous doctor did not prescribe eardrops. Pretty straightforward. Dr. Cloud is able to prescribe the medication and is able to review the entire plan with the patient. So having done all that, we've now checked off a couple things, again, with the advancing care category and with the clinical quality measure. You'll see where all this is going to come into play at the dashboard at the end. Another patient, patient Freddie, frequent flyer. The staff knows Freddie real well. He's here all the time. 42-year-old patient with postnasal drip and a sore throat. The staff is pretty convinced that this patient is a potential for having depression. So that's really the key factor in this particular case. When we see Freddie, Freddie's going to get checked in at the front desk, and the front desk has the ability to print out, in my example here, a health depression screening form. The form is a CESD form, for those of you who want to know. And the front desk staff is able to give Freddie a special pen, and when Freddie fills out the form, the pen will automatically score that depression screening test and put the results into today's chart for the patient. You can talk to one of our practice specialists on a different day. Sophie's one of our team members over here. She'd be happy to call you guys and set up a time to talk with one of us. Ask about this particular feature. This is actually a really great feature where it's just a regular ballpoint pen using regular paper off of a regular printer. So nothing special with the paper, but the pen has a camera on the end of it and can pick up where those check marks are being placed on a form and load the form and the answers, in this case, into the patient's chart. So a really unique feature that ENT-Cloud has. So when the patient goes in the room, Dr. Cloud walks in. Because Freddie is here all the time, okay? Freddie's here constantly. Here's something that's unique about ENT-Cloud. All of that patient's prior review of systems and all of their history, all their physical exam, all those things are going to be automatically copied into today's note. Because just a quick history here about EMR systems. When EMR systems were first designed, they were designed for primary care. And primary care and in family medicine and so forth, you had a patient coming in for different things every single time. So the ability to copy things forward from one exam to the next wasn't as important as it is now. So in our system, we can do that, copy forward all that information from a history, all that diagnosis and plan are all copied into today's note. The exam is copied forward. Now here's the key thing from that form. So Freddie filled out the depression screening form. The results come up on the screen. Dr. Cloud can see the score and specifically see what the testing, what the score was on that particular test. Because she reviews the test, it's quickly and easy to see that that Freddie is probably suffering some depression. In the discussion with the patient, she's going to identify the nose and throat issues are related to crying spells due to the depression, and suggest that the patient go and see a behavioral health professional. And that referral message can happen all in one step as the patient is leaving. So as the patient is leaving, we have the ability in our software specifically to take the information from the patient, send a referral message over to the behavioral health professional in this case, and a copy of the patient's continuity of care record. So we can both send the message over, referral doctor, we want you to see our patient, and we would also be able to send over a continuity of care record for the patient. And that's, again, part of the improvement activities. Let's talk about what this kind of comes down to at the end. Okay, so at the end of the day, when we're looking at things like reporting measures and so forth, you sit down, you want to be able to see how you're doing. And if you can't see how you're doing, how do you possibly measure against it? So in this particular example, we're going to look as the doctor's going to sit down here at the end of the day and is able to see things like what percentages are looking like based upon the dashboard. So you're expected to report on different percentages of patients being seen during the attestation period, whether it's for the whole year, whether it's a 9-day period, 6 quality measures. You'll be able to select, per provider, so you'll be able to run this on a per provider basis. The quality measures, out of 271 for each provider based on specialty, subspecialty, and patient population seen. So we can run those reports based upon all that criteria, and you'll be able to see how you're doing percentage-wise on the quality measures. Okay, and because you can select the dates, that's part of what I was getting into earlier, which is that you can select which 90-day period you want to look at. The dashboard, so at the end of the day, we have our, Dr. Cloud is going to be able to look at that dashboard and be able to see how she's doing on each of these things. Okay. In the case of my example here, Dr. Cloud at the end of the day has a meeting with their clinical team leader over here at ENT-Cloud, and she's able to go over with their, let's say their MIPS specialist over here, what the reports are that she should be running and is already familiar with the ones that she's already been told to be run, and we can continue to consult with her about all these different aspects and as they change. And that's a key component here, because even if you learned everything there is to know about MIPS and MACRA, it will be a little bit different tomorrow and so forth. Some of those reports also include improvement activities. In this case, and here's some of these numbers we were talking about earlier. It's 4 implemented improvement activities for patients during the period. So it's 4 out of 92. And the report is run by provider, and it is a yes-no in the self-attestation. And you'll see where some of these things come into play. Where does this all boil down to? My expectation, if you're on the phone with me right now, you're probably concerned about the money. So I think that it's important to give an example here of what this actually looks like. And as it relates to the actual cash piece of it, let's give the example here. So Dr. Cloud is doing $800,000 in gross revenue. This is not just Medicare. We're talking about everything, obviously. So $800,000 in gross revenue. 30% of our practice is Medicare. Out of that 30%, so that represents about $240,000 in revenue. How does that fall into play? So for 2017, the incentive or penalty is plus or minus 4%. Now again, that number is going to be reflected in the payments that are coming in 2019, but it's based upon the data for 2017. So it's a plus or minus 4% swing either direction. So what that means is really it's not $9,600, it's actually $19,200. It's twice that number because the swing goes that far. In 2018, again, the 5%, so 24,000, 7%, you get the idea here, 9% in 2020. If you add all these numbers up, we're talking about $60,000 plus or minus, so a total swing of $120,000 difference over the course of a 4-year period. Not to mention beyond, because this definitely goes beyond the 4 years. I'm just talking about the 4 years immediately. So a fairly significant amount of money for this Dr. Cloud in private practice by herself. That is a quick overview of what MIPS and MACRA and how it applies to the daily activities that you do as a provider and as a practice. There's a few things that I just want to mention, and then I am going to open it up for questions here with Risa here in a second, and she'll be able to answer some of your questions. If you haven't put your questions in on the side app on the GoToMeeting, you're able to do that, and feel free to be as specific as you like on your questions. I think that a couple things that I'd like to say, and I'm sure that Risa will pick up some more items here too. When you're picking some of the measures that you're going to be tested on, pick the measures that you are most likely to be able to succeed. So in some of these cases, you get to pick and choose the measures that you want to report on. Don't pick things that are incredibly difficult to go get at. So pick things where you're able to succeed, and we would certainly be happy to help you do that on our software. We are constantly providing ongoing training to all of our clients out there, all of our ENT physicians across the United States, and we will also have a step-by-step how-to guide to fulfill all the requirements for MIPS and MACRA for all of our users. We do have a guarantee as it relates to MIPS and MACRA, and I would encourage you to talk with one of your practice specialists, and again, I will have Sophie reach out to each of you to see if we want to set up a time to maybe see more about ENT-Cloud, what we're actually doing as far as our software is concerned, and that magic pen that I referred to, the digital pen that can automatically bring in some of the testing and scores. And lastly, for me, and I'm going to hand it over to Risa, is I do want to encourage you that you can do this. This is not something that's rocket science. This is something that will be documentable, and because we have the reporting with the dashboards, you'll be able to see exactly where you're hitting as far as the measures are concerned. So we'd be happy to talk with you about that much more in detail on an individual basis. And again, Sophie will reach out to you to set that up. But I will open it up right now for any questions that you have.
Hi guys, it's Risa. Again, I'm the Director of Clinical Services for WRS Health. Dave did allude to it. I do troll the internet on a daily basis on the CMS website because it is a constantly changing landscape. So I like to think that I'm up to date on just about anything. Please go ahead and forward any questions. You can do that through the questions module of the GoToMeeting dashboard. Dave advised you that the GoToMeeting dashboard is probably that rectangular light blue window hanging out on the right side of your screen somewhere. We will read the questions aloud because a lot of times what you may be wanting to know is what somebody else is thinking as well. I do have a question that has come in. Somebody's asking how is the calculations done for the improvement activities category. Just to let you know, the improvement activities category is the newest category, not based off of any prior meaningful use purposes. And there is actually no benchmark. It is a self-attestation, meaning that you would select 4 of the activities, you'd initiate and implement those activities, and then you would attest yes to the 4 activities. WRS also advises that for any improvement activities, because it is a self-attestation of a yes or not taking it as a no, that you should probably populate a workflow or a procedural policy manual that you've got in case there's an audit after the fact. Somebody had their hand up. I didn't see it, but then they put it back down. Again, if you have a question, please put it through the questions module of the GoToMeeting dashboard.
Risa, could you talk a little bit about the secured messaging? I think that's a pretty key part, and you do a really good job of overviewing that.
Well, secure messaging, direct messaging. Actually, you could not pass meaningful use for 2016 if you didn't have direct messaging, because it is a criteria for the meaningful use measure 5 for 2016. 5B, as a matter of fact. 3 of the basic advancing care category measures will require that you use direct messaging. The 5 advancing care categories, remembering that advancing care category is literally based off of meaningful use that we've all known and loved for the past 6 years. One is the security risk analysis, one is e-prescribing, one is provide patient access, which also gives the patient the opportunity to electronically send their CCDA, which is their continuity of care document, electronically to another provider or facility from their portal. That can only be done by direct messaging, so there's one. The basic measure 4 is send a summary of care record, which is actually one of our meaningful use measures right now. For all of your transitions of care referrals, you should be sending a CCDA electronically to the referring or referral provider. That can only be done through direct messaging. And then the 5th of the basic criteria, when I say the basic criteria, these are the 5 basic measures that you must pass through the advancing care category. The 5th one is a new one. It is called summary of care measure, but as opposed to you sending the CCDA electronically through direct messaging to someone else, it is you receiving through direct messaging a CCDA on a new patient that you have never seen before and importing that data directly into the patient note. When I say importing, what that means is you will take that incoming CCDA, you'll associate it and assign it to the correct patient, and you'll actually be able to import the medications list, the allergy list, and the problem list.
Risa, did you see the question from the gentleman who had his hand up? If not, I can read it to you.
Yeah, I don't see it.
I have it. The question was, most of my patients are not computer oriented. How can I communicate with them via a patient portal?
Okay, well, I have to tell you, don't sell your patient short. I tell this to my clients, my WRS health providers all the time. Don't sell your clients short. I know that people are going to say, oh, you know, some of my patients can't afford a computer, some of my patients don't have internet access, or some of my patients are elderly. Don't sell them short. because I'll be honest with you, CMS is not going to listen to those excuses. They've set the benchmarks, and you are required to meet those benchmarks. The only way that you can get out of attesting to criteria that require your patient to be able to address the portal is if you live in a county that has greater than 50% of the population without access to high-speed internet. Not that they don't have the high-speed internet, but that they don't have access to it. That's really a very small population in the United States. So those are the only ways that you can do it. What I always say is it's the way you address it with the patients. Instead of your front desk person telling a patient, give me your email address, I'm going to need it. To be honest with you, I wouldn't give you my email address. The better thing is in the delivery. Instead of asking that way, have your front desk person say, hey, you know, we're electronic now. You can access your notes. You can send your notes. You can ask messages. You can request appointments. You can ask for a prescription renewal online. All I need to have is your email address so that we can get you hooked up to the portal. It's actually more in the delivery. More failures, from my point of view, happen at the front desk because the front desk doesn't want to capture the data. Did that answer it?
Are there any other questions? Any follow-up questions? What we just chatted about? Well, again, assuming there's no more questions, if there is, feel free to type it in. But just in closing, you know, ENT-Cloud, we're pretty proud of our solution over here, both with Dr. Gordon and Dr. Lee and our entire team over here. We've put together a really nice system for ENT physicians, obviously also encompassing audiology as well as allergy. We have a very nice system. We'd love to show it to you. We didn't want to do that today. We wanted to spend most of our time talking about the MIPS and MACRA requirements. If you'd like to see more about our software, Sophie will reach out to you guys and set up a time for you to talk with one of our practice specialists, and we'd be happy to take you through that solution. Again, that pen that we have, that magic pen as I call it, is worthwhile having a discussion just based upon that itself. And again, we do have a guarantee as it relates to MIPS and MACRA. If you're just trying to make sure that you at the very, very least don't hit that penalty, we can guarantee that you will not get penalized. So do ask about that as well. Any last minute questions? Reese, any last thoughts?
No, I think it's doable. I have to tell you, it is not what I thought it was going to be. Again, like I said, I troll CMS all the time, and I have not been anticipating this day. But the reality is, it is actually not as awful as I thought it was going to be. When I think back to the old days of 2011, oh my gosh, I'm considering 2011 old, but back to the old original days of 2011, all of those measures that they had, there were 25 of them, and they had such strict benchmark settings. They were actually harder to do than the new MIPSs. And I'm sure that in 2018, it's going to be a lot more difficult, that the benchmarks are going to be higher and the criteria are going to be more stringent. But 2017 is literally a transitional year. And I think the reality behind that is because this is not just new to you, it's new to the EHRs, and even more importantly, it's brand new to CMS as well. So everybody's on the same learning curve.
I do have a last minute question here, Risa. The question is, can an MA enter the depression screening analysis directly with the patient without the pen? And of course the answer is they could enter it, but they couldn't charge for it. Is that right?
Well, they can't charge for the computer generated. No. So you can obviously do it, and to be honest with you, even just generating the form itself and asking the questions is a quality measure. It's not an improvement activity, but it is a quality measure so that we get good quality of care for patients, but you cannot generate that, that code that specifies whether it was computer generated.
And if it is computer generated, that is a reimbursable code all by itself, so it can essentially pay for the pen is part of my other comment to that.
It can, but you also remember when you do that, you need to show in your note process and that you've done that. Not only that you've asked the questions, but that you've followed up on it, that you've taken an assessment of the patient, and that you've given a plan of action for the patient as well, including reviewing their medications and reconciling them.
Thank you for that clarification. All right, guys. Again, thanks for joining. We really appreciate you spending the time. I'll have Sophie follow up with you guys, and also we'll make a copy of the recording of this video available to you guys as well. Thanks for joining, and we will chat with you soon.
Happy New Year.
Happy New Year.